it on? Is it on? Good. This is a very interesting question. What can we do, what can you do to achieve Vision 2020? I thought that this might be even better to have a roundtable and discuss a little bit the subject, but I will go through the motions with the presentation, and we might have some time later on because I really would like to discuss with you more and more of what is feasible. So I'm just going to give you some thoughts and ideas. First of all, I say every ophthalmologist or anybody in healthcare is doing Vision 2020 already. By taking care of your patients and giving in the best care excellence, treating a cataract or putting laser to a diabetic or making the diagnosis or helping people with refractive error, that is Vision 2020. What we need to scale it up and to make it available everywhere, well, that's still a challenge that's ahead of us, and we need to see how we're going to do this. And I'm going to start by saying one of the issues, the main issues, that we have to understand our community. And when I say that, it is in my mind, I would love to ask you guys later on a little bit, how good do you understand the community where you are currently? I mean, do you understand the minorities groups that are around your own town or in your own state? We're not talking just international. How well do you know the environment in which you are involved currently? There must be people out there which are not been covered by the system. And what are you doing for them? So the whole presentation has always two connotations. Think of it like Vision 2020, my local, and Vision 2020 international. And so what can we do at both levels? The first level is to understand the community. There are people, there are barriers that people have to access care. And this is not just money. This is usually they live in very remote places. They are afraid of the service. Sometimes they don't even know it's possible. They just think they are blind and they're going to stay blind. They belong to poor communities. Funding is, and also family issues. I'm in Paraguay. I've been going to home to some of the places asking for a blind person, and they will show me the father or the mother, which is about 50, 60. And then I have to ask twice or three times, is there anybody else in the home? And they would say, oh yeah, well, grandpa, but he's very old. You know, but I would like to see him. I don't think so. He is. So it's sometimes the barriers is the own family. They don't want to take care of their elderly. And once you go back in this little dark room in the little house there somewhere in the village, there is this old 75-year-old man, blind due to cataracts, that if you do operate on, the guy walks around and the family is ashamed that we're putting him away in a small room waiting to die. Understand the community. Really understand the places you're planning to go in the future. You know, what is the situation down there? How do people react? What do they want? Quality is another big issue. The quality is not just about the patient itself. It's also about the people, the centers that you're working with around them, and also what is the eye care system as a total. What's the quality involved at that? And I think cataract surgery has become a proxy lately, that more and more NGOs around the world are trying to monitor the projects, not just on volume, but also on the quality of the service. And indirectly, we can go and make population-based surveys, like the rapid assessment or the RAPS, and find out some data. It's interesting that there's this study done in Asia where you see that up to 50% of, but the line is about 30%, of the eyes have a visual acuity less than 2200 with available correction at some of these different places after cataract surgery. That means 1 out of 3. And if this is quality, definitely it's not. But that's what's out there. That's what the people know. In Latin America, I did a survey in Paraguay, and I'm just going to show you some of the data. We did a national survey. That's about 10 years ago now. And we found that all the 3,000 and some patients that we examined, people going house to house at random, 93 people already had a surgery. And out of these that had surgery, 19 were with no intraocular lens, and the vision was less than 2200, which means 50% of the patients. But once we take the 6 eyes that were less than 2200 with intraocular lens, that represents 11%. But for the patients or the community, it's still at 27, because they just know I've been operated on cataract and I can see. If you ask any ophthalmologist, is it true that 1 of 3 or any 1 of 4 of your patients is seeing less than 2200? I think not even Latin America, nobody says that's true. But if you go into the community, you find that is the truth. And this is not just in Paraguay. We did it in a couple other places in Latin America. This is Argentina, Buenos Aires, 8%. Brazil, Campinas, very close to Sao Paulo. 23% in Peru. Guatemala has 31, and this is 11. All of these are with IOL. We're taking the best case scenario. So if you take those with aphakia or complicated cases, that's even worse. Quality is a big issue. And think of if we're going into a country doing some of these mission trips, how we monitor the quality and the results. Who's taking care of that? Who will we be accountable on those results that we're having at these places? The other thing is appropriate technology. And we understand that whatever works in one place doesn't work in the other. This is in Japan somewhere. This, I think, it's India. Whatever works in one place doesn't work in the other. And whatever we are accustomed to do at home, it may not work wherever we go. If we want to serve a new community, minority groups around our homes or cities, probably have to do it differently as what we do it in our own clinic. Because the community demands something different. The whole system has to be thought differently. And if we go to Africa, it's definitely different. Appropriate technology also comes about the debate about surgical technique. In Latin America especially, this has been going on for quite some time. Small incision versus phaco. I think as long as we have segments or groups of people with different priorities, there should be different techniques being applied because there are different needs. So as long as you have patients from a higher capacity paying, they're striving for equality, they're looking up for something, I think phaco is definitely the best technique out there. I do phaco, and we promote it even in our clinic. But over 90% of all the surgeries done at the Fundación Visión in Paraguay is small incision because it's lower in cost. And I think the residents, once they go out in the field, 70–80% of my patients in Latin America do not have health insurance. They have to do it out of pocket. So who's going to pay the bill if they're just trained with phaco? They need maintenance of equipment and so forth. And there is this whole debate about the safety and efficiency and the results. So I just give you a couple works out here. And this is a very interesting study that was done by David Chang and Tabin and Dr. Reed in Nepal, because they did about 100 cases consecutively, blind, double-blind case study where they decide it's going to be phaco or it's going to be a small incision. And the results in the post-update number 1, they found that small incision was a little bit better because the very dense nucleus had a little bit more corneal edema. But that kind of inverts itself a little bit 6 months later. But statistically, it's not really significant. What I'm saying is, I think small incision is out there as a very good technique in places where phaco, in all its what it implies, is not available. Funding, very limited funding, and I think I'm going to finish with this subject here, and it's that in most of the countries around the world, they spend about $10 per person per year on eye health. This is not very much, and what you need to do is the challenge is how with that money you're going to be now doing high quality in very remote areas. If you want to take your service to a remote place, it's even more costlier. And so we need to think differently. It was all summer, I think, in one of the meetings, and I heard recently Ruben Belfort from Brazil kind of saying, why do we have to train someone for 6 years as a doctor and then another 3 to 4 years as an ophthalmologist before he can do out there in the field do a cataract? Why don't we take a kid out of high school, train him for 1 year, and may have him do cataract surgeries? Or why don't we take a nurse and train her well and do cataract surgery, something that is done in Africa and some of the places. But let's just make it official. One of the advantages that I think all summer was kind of saying is, if we train an ophthalmologist, he can move over around the world and look for a better place to work. If you take a kid out of high school and he is the hero of the neighborhood because he is a good cataract surgeon there, he cannot practice ophthalmology or medicine anywhere else. So he will stay in one of these rural areas and villages. What I'm saying is we have to reevaluate how we do things. And that means completely out of the box. And there are people thinking about this. How can we deploy cataract services at a lower cost with the limited resources we have? $356 billion is the total health expenditure in low and middle income countries. Eye care health expenditure is just 2 to 5% of that overall budget, which is about $13 billion. Government are putting in about $6 billion. The NGOs, that means all of us with our activities, are putting about $0.3 billion. And drug donations, Pfizer, Mectizan, Alcon with foundations and donating all of these projects together might be another 0.4. And then you have $6 billion, which comes out of the pocket insurance or some other kind of funding. So you see that whatever our NGO kind of approach here will be, it always will be just a fraction of what is needed to take care of eye care around the world. This is why I'm convinced, and I had to change my chip in my own mind, that approaching governments is a very, very important thing that we have to do. Doesn't mean that we as ophthalmologists have to do it, but somebody has to do it. Either we have to finance it, we have to be on the agenda. And there is an interesting case from Vision 2020 Australia. They collected data. That's the first step, how they did it. So they got a bunch of data of the economic impact and cost of vision loss in Australia. Second, they did some strategy interventions and what are the main diseases in Australia. Then they went on and did some analysis of interventions. Is it cost effective, one treatment or the other, and should the government involved in it or not? Also for glaucoma. And with this data, they went and came together as NGOs, came up as a forum, went and lobbied to parliament people, did some awareness programs in the community, and they actually engaged the government systematically as a group, and they were able to get the National Framework for Action 2004. They got 30 million over 4 years for 25 Vision 2020 projects. The Australian Blindness Initiative gave them 45 million through the US AID program, and Vision 2020 is being funded with about 600,000 a year for their yearly program. Where should our NGOs be able to raise that kind of funds on a yearly basis or for these programs? I don't think we're able to. But governments can. But we can just approach them if we go as a group. So there is something that we can do at that level. What they recognized as what could be done better, the Australian ophthalmologists slow to embrace Vision 2020. This was one of their things that they realized. A bunch of others, which I will not go into detail. And this is a presentation that I will leave with Stan to distribute later, I think with CD or webpage or something. Very good presentation from Professor Hugh Taylor, making a case for government. So I will not go into this. Did you know there is a Vision 2020 USA? I think they're getting together, I think, the last 2 years. Lou Pizzarello is the person that is chairing this. This is their address, their email. Please look them up. I think COS should be part of that, of Vision 2020 US. And these are just some of the ideas of things that can be done. This little girl is a Paraguayan patient of mine that is bilaterally blind. She's not waiting for a miraculously technique or a surgical technique or something to be cured. She's been waiting for more than 5 years that someone takes care of her. This is not about a new IOL or anything. This is just about taking care of those in need. And currently, we're not able to tackle this. And we have to think it differently. In John 4:34, Jesus says, and they're white and ready to harvest, he says. But he didn't say it about cataracts. Well, maybe he did, but not in that way. He said, say not ye, there are 4 months, and then cometh the harvest. Behold, I say unto you, lift up your eyes and look at the fields, for they are white and ready to harvest. And this means that's a calling for us to go out there, not just help people with their sight, but also with their spiritual sight. Thank you. Yeah.
Just put on mute.
Yeah.
Rainald, thank you for that challenge. It's interesting how this came together because as we were brainstorming this meeting, we said, you know, missions isn't necessarily just international. We need to think about what we're doing locally. And in fact, Alcon was one of the ones that challenged me to say, hey, why don't you talk about local missions? And so this year we actually have a focus on local missions that Dr. Garrett, Dr. Rice are going to be sharing about. So I thought that was interesting how that kind of came together. We're talking about international missions, but it's what can we do here? And I think it's interesting for us to examine, you know, as we look at the Medicaid cuts and Medicare cuts, and doctors are saying, I can't take care of Medicaid, you know, I can't afford to. It's a challenge to those of us who are Christians to say, what's the right thing to do? And if you can't afford for your office to do Medicaid, how are you going to be involved outside of your office doing Medicaid or less than Medicaid in your community? So that's a challenge for me. It's a challenge for you if we practice in the United States. Our next talk will be with Dr. Hopkins again. He's going to tell us a little bit about his time in the Congo forest. Is it called Pimu?